My name is Sophie Soclardis. I'm a scientific director and senior scientist here in education, and it's a real pleasure to be with you here today. And I look forward to a very thought-provoking talk by Dr. Dominic Sisti. So this event is a collaboration, actually, between Bioethics Research and our Education Achieve Day. So the collaboration is between the 18th Annual Use Lecture and our year-long Education Achieve, where we have monthly events celebrating all things education. And the theme for Education Achieve this year is Inclusive, Caring, and Accountable Learning Cultures. So how apt to have this incredible talk by Dr. Sisti. Events like this provide us with the opportunity to continuously learn from one another, improve the way we work, and advance the care of our patients, families, and the community. So I'd like to introduce now Dr. Jennifer Gibson, who will tell us a bit more about the Use Lecture.
Thank you, Sophie, and welcome everybody, both in person and online. It's really a pleasure to be joining you here today. My name is Jennifer Gibson. I direct the Joint Center for Bioethics at the University of Toronto. And, you know, this is a beautiful space. It feels really like this is a space that really fosters creativity, some big thinking, some good thinking. And so really hope that today, through our conversation together, both in person and online, after Dom's talk, we will be able to move forward in some of our shared collaboration in thinking about psychiatric ethics. I'd like to share a little bit about today's lecture, the Use Lecture, but first I'd like to invite us to open this gathering in a good way by acknowledging the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. The mandate of the Use Lecture is to bring internationally recognized major contributors to promote and disseminate understanding of the ethical, scientific, clinical, and social implications of advances in genetics, neuroscience, psychiatry, and related fields. I would like to take a few minutes to tell you about the two remarkable people who are responsible for the Use Lecture series. The Use Lecture series was created by Dr. Carolina Use in 1994 in honor of her late husband, André Use. The story of their lives together is recorded in their autobiographical book, Our Journey in the Valley of Tears, published by the University of Toronto. The life story of the Uses is the story of science. Both André and Carolina were scholars in the neurosciences. André was chairman and director of the Psychiatric Clinic at the Medical Academy of Warsaw, president of the Polish Psychiatric Association, and author of more than 200 scientific publications. Their life story is also the story of heroism. When André, a Polish Catholic, married Carolina, a Polish Jew, during the Nazi occupation of Poland, he protected her from persecution. At the same time, he made himself a potential victim of the Nazi terror. By marrying a Jew, André subjected himself to the same risk of persecution that he would have faced if he himself were Jewish. Most fundamentally, though, their life story is a love story. André and Carolina fell in love on the day they met, October 16th, 1940. Their love continues to this day, and in it one finds hope. The final paragraph of their book reads as follows. André was holding tight to Carolina's hand. His existential anxiety was gone. The past was known, and it was full of atrocities. The future could only be better. God seemed to André to be very close and listening to them. They closed their eyes, holding each other close. When they opened their eyes, it was already dark. The peaks of the mountains were scarcely visible. A mild, very mild wind was blowing from the east. Sometimes such mild winds bring long-lasting, beautiful weather. Sadly, Carolina died in November 2002, and we are honored that she chose the University of Toronto Joint Centre for Bioethics to perpetuate her husband's memory. We are also very grateful to her for providing us with the opportunity to invite distinguished leaders from around the world to deliver the annual Use Lecture. She and Anjay will not be forgotten. The format of today's lecture is a presentation by our speaker, followed by an interactive discussion period. Today's lecture is being webcast via WebEx. If you speak during the discussion period, your voice will be recorded, but your image will not be seen. This lecture, along with other archived lectures, can be accessed on the Joint Centre for Bioethics YouTube channel. And may I ask you right now to please take a moment to set your mobile devices to vibrate and silent, or silent, as the case may be. Thank you. Now it is my pleasure to invite Dr. Daniel Buckman, Senior Scientist and Director of the Everyday Ethics Lab at CAMH, to introduce today's speaker. Daniel.
Thanks so much, Jen, and thank you all again for coming. First, I just want to extend my thanks to Tanya SRE and Owen Daly for all the help in facilitating the lecture today. And also thanks to Dr. Sisti for your generous time today with students and colleagues and staff. So it is now my great pleasure to introduce Dr. Sisti. Dr. Dominic Sisti is an associate professor in the Department of Medical Ethics and Health Policy at the University of Pennsylvania, where he directs the Scattergood Program for the Applied Ethics of Behavioral Healthcare. He also holds secondary appointments in psychiatry, where he leads the residency ethics curriculum, and in philosophy. His research focuses on ethical and policy challenges in mental health care, including long-term psychiatric care, ethics in correctional settings, and the emerging ethics of psychedelic research and treatment. His work appears in leading journals such as JAMA Psychiatry, Psychiatric Services, Hastings Center Report, and the Journal of Medical Ethics, and has been featured in outlets including the New York Times, The Economist, NPR, the Philadelphia Inquirer, Slate, and The Atlantic. He is co-editor of Applied Ethics in Mental Health Care from MIT Press in 2013. His research has been supported by the Scattergood Foundation, the Greenwald Foundation, the Quattroni Center, the Leonard Davis Institute, and the Dana Foundation. He teaches graduate courses on clinical ethics, behavioral health ethics, and digital media and bioethics. Dr. Sisti earned a BA in biology from Villanova University, an MBE from Penn, and a PhD in philosophy from Michigan State University. He was an Edmund Pellegrino Fellow at Georgetown Center for Clinical Bioethics and is a Hastings Center Fellow. Dr. Sisti, the floor is yours.
Well, thank you all for coming. I know it's so cold outside. I appreciate you weathering the storm here. So I just want to begin by thanking everyone at the Joint Center for Bioethics and CAMH for having me, Jennifer Gibson, Dan Buckman, and Terry Ewan, who I don't think is here today, for inviting me to Toronto and making this lecture possible. I'm very grateful and humbled to be able to give the 18th Use Lecture today. This invitation has given me the opportunity to organize a set of concerns about the future of bioethics as the political conditions that shaped it weaken and as authoritarian advances, particularly in the United States. I acknowledge and thank colleagues who helped me think through these issues, including Arthur Kaplan, Ben Barsky, Jonathan Moreno, and I thank my colleagues at Penn who helped me revise an earlier version of this lecture. Thanks to the Scattergood Foundation for supporting my work over the years. I have no conflicts to disclose. Like many of you here, I was trained in a version of bioethics that treated individual rights, liberties, and protections against exploitation as foundational and as uncontroversial. Respect for autonomy occupies the center of the field, sometimes to a fault. From the Nuremberg doctors' trial forward, through Tuskegee, Willowbrook, Rowe, Quinlan, Cruzan, Shivo, bioethics developed alongside a steady expansion of biomedical liberty. Research ethics was catalyzed by public outrage when medical abuses were exposed by the press. Healthcare decisions became widely understood as private matters, mediated by families and clinically trained professionals. They were supported by policies and norms and institutions based in transparency and scientific credibility. I assumed those background conditions would always persist. That assumption was naive. Historian Ruth Ben-Guyot describes how authoritarianism causes moral degradation, the erosion of norms that once constrained cruelty, corruption, and abuse of power. As those norms erode, behavior that was once previously unthinkable becomes ordinary, rewarded, or ignored. Institutions hollow out, as do individual professionals. This is why authoritarianism poses a distinct challenge to professions that rely on self-regulation, including law and medicine. At the same time, we see epistemic degradation, where basic facts are rejected, ignored, or distorted. Stephen Toulmin's 1982 essay, How Medicine Saved the Life of Ethics, defined the period of time during which applied ethics could anchor itself in shared facts. Disease was understood as an objective harm. Antibiotics worked. Vaccines worked. Empirical claims were contested methodically rather than rejected outright. Ethical reasoning could attach itself to stable truths, and bioethics gained legitimacy by aligning itself with evidence-based medicine. This epistemology has been inverted. Scientific consensus is now treated as ideological preference. Expertise is dismissed as fraud. Facts are rejected when they conflict with political or financial interests. In a commentary published just last week in the British Medical Journal, Gavin Yamey and Jonathan Schaefer argue forcefully that Trump and Secretary Kennedy's public health demolition is being enabled by high-profile physicians who appear beside them, lending clinical credibility to lies and helping to normalize damaging policy shifts. They're complicit in the formation of an authoritarian state. When doctors collaborate or stay publicly silent, they become part of the machinery dismantling evidence-based public health, which is one goal of an authoritarian. This troubling dynamic raises a deeper question for bioethics itself. What happens to ethical frameworks built on trust and medical expertise, honest institutions, and professional self-regulations when those conditions no longer hold? Recognizing this dynamic on a global scale, Jonathan Moreno's recent book, Absolutely Essential, suggests bioethicists must now rethink assumptions about the permanence of the institutional and political conditions that gave rise to modern bioethics. Moreno discusses the bedrocks of bioethics, informed consent, research oversight, and professional self-regulation, and how they all depend on a certain set of political conditions: stable institutions, functional courts to constrain power, and respect for due process. Ultimately, respect for individual liberty. Bioethics, as it developed within liberal democracies, is now poorly equipped for the authoritarian conditions we increasingly find ourselves. In this talk, I take Jonathan Moreno's observation and focus on how it applies to psychiatric ethics. My claim is that psychiatry exposes this vulnerability starkly because it sits at the intersection of medicine, law, and state power. I'll illustrate this with several historical examples of psychiatric abuse and violence. I'll then discuss the recent executive order by President Trump on homelessness and crime that begins to operationalize various forms of authoritarian overreach into clinical psychiatry. I'll end by describing how a return to first principles, respect for persons in particular, as well as a re-emphasis on professional and individual virtues, may help individual clinicians bear witness and mitigate the ethical risks to psychiatry and harm to patients. So, over the past decade, many of us have had to educate ourselves about how authoritarianism works and have become familiar with its so-called playbook. Writers such as Timothy Snyder, Robert Paxton, Ruth Bangayat, and Jason Stanley have described recurring features: scapegoating, the medicalization of social problems, erosion of professional independence and ethics, and the use of administrative loopholes to bypass legal safeguards. Psychiatry is unusually vulnerable to political co-optation by authoritarians. It is one-stop shopping for dictators because psychiatry authorizes the grounds for confinement and determines competence and deviance. In a sense, psychiatrists are socially sanctioned judges and juries of social deviance. These are the perfect people to pressure, coerce, or bribe by men who behave like mafia bosses. Walter Reich reminds us that psychiatry has been criticized for abuses, especially unjustified involuntary commitment, coercive treatment, and technologies that control behavior. He argues that what unifies these concerns is the act of diagnosis itself. The authority to diagnose determines who is subject to psychiatric control. It legitimates coercion, and it drives treatment decisions. With this in mind, in July 2025, the Trump administration issued an executive order titled Ending Crime and Disorder on America's Streets. The order explicitly centers civil commitment, institutionalization, and expanded police and psychiatric coordination as tools of public order. It frames homelessness primarily as a problem of mental illness, addiction, and dangerousness, and calls for loosening legal and procedural constraints on confinement in the name of safety and compassion. I want to suggest that this document is not an aberration. It reflects a recognizable pattern that appears whenever psychiatry becomes aligned with state goals of control rather than therapeutic care. What I'll present now are a few examples of how psychiatry has been weaponized in the context of authoritarian conditions. A couple of these examples may be familiar. The details differ, but the basic pattern is the same in that authoritarian overtake of psychiatry happens when phony psychiatric categories are created, confinement laws are loosened, and pseudoscientific beliefs, eugenic ideologies, are used to justify these things to professionals and to the general public. Our first example is drapetomania, concocted in the antebellum United States by Dr. Samuel Cartwright. Cartwright was not a fringe figure. He was medically trained at the University of Pennsylvania, widely published, professionally celebrated, and was later appointed of, quote, diseases of the Negro, unquote, later appointed professor of diseases of the Negro at the University of Louisiana. In 1850, he proposed the concept of drapetomania as a psychiatric diagnosis to explain why enslaved people attempted to flee bondage. Cartwright described escape not as a rational response to enslavement, but a form of mental illness marked by what he called rascality, dissatisfaction, and disobedience. The diagnosis pathologized the desire for freedom itself and located the problem within the enslaved person rather than within the institution of slavery. Psychiatric authority was used to naturalize the ultimate form of authoritarianism, slavery, making the desire to be free a symptom of disease and brutal domination. Cartwright prescribed, quote, beating the devil out of them as its treatment. Excuse me a second. Fast forward to Nazi Germany. Psychiatry became actively involved in sterilization, euthanasia, and mass murder. By 1939, psychiatrists provided diagnoses and administrative infrastructure for the confinement and killing of mentally ill patients, starting with children under the T4 killing program. Despite the strong medical ethics code that existed in the Weimar Republic and under which many of these psychiatrists were likely trained. Historical work by Israeli psychiatrist Rael Strauss reveals that psychiatrists were not peripheral to Nazi atrocities, but central architects of them. Strauss shows how leading psychiatrists actively designed, legitimized, and implemented programs of compulsory sterilization and so-called euthanasia, which resulted in the murder of hundreds of thousands of people with mental illness and disabilities, before and alongside the Holocaust. These psychiatrists were not coerced. Many embraced Nazi racial ideology, framing killing as a medical and scientific intervention in the service of the public health and racial hygiene. These were elite figures within the profession, not extremists, who mostly went on after the war to continue practicing psychiatry. As I recently read, only one physician was appointed to command a Nazi death camp. It was a psychiatrist. His name was Imfried Eberl. He became a commandant of Treblinka in 1942 after serving as a superintendent of a psychiatric hospital that was involved in killing patients. He reportedly patrolled the camp dressed in his doctor's white coat to try to reassure victims before they were gassed. Our next example is Soviet psychiatry. As Sidney Block argues, Soviet psychiatry was structurally subordinated to state ideology, making political abuse possible and routine. All psychiatrists were state employees in the Soviet Union, working within a centralized system that was aligned with the Communist Party. They lacked meaningful professional independence, producing persistent conflicts between loyalty to patients and loyalty to the state. Psychiatric theory itself was reshaped to serve political ends. Psychoanalysis was suppressed, and diagnostic criteria, especially for schizophrenia, were dramatically expanded. These changes allowed political dissent to be reclassified as mental illness and punished through indefinite involuntary hospitalization. This logic was articulated openly by Soviet leadership. In 1959, Nikita Khrushchev argued that opposition to communism reflected an abnormal mental state, explicitly collapsing political deviance into psychopathology. It provided ideological justification for psychiatric repression. He said, and I quote, "A crime is a deviation from the general recognized standards of behavior frequently caused by mental disorder. Can there be diseases, nervous disorders, among certain people in communist society? Evidently, yes. If that is so, then there will also be offenses that are characteristic for people with abnormal minds, to those who might start calling for opposition to communism on this basis. We can say that clearly the mental state of such people is not normal." In 1980, the Dutch Sovietology professor Robert van Voren co-founded the International Association on Political Use of Psychiatry to document and expose cases of abuse in the USSR. His work actually continues today as head of the Global Initiative on Psychiatry, which tracks and compiles lists of cases of psychiatric abuses in Russia. We should note Putin continues to exploit psychiatric confinement to disappear his critics. Here's one example, and there's a whole spreadsheet of examples that if you go onto the Global Initiative on Psychiatry's website, you can see. In October 2024, Yevgenia Yelazar, a Krasnoyarsk-based environmental activist and politician known for her outspoken opposition to police violence, waste reform, and Rostom-linked projects, was detained by authorities without prior summons or notification. Despite having been actively attending court proceedings related to her husband's arrest, she was told that she was wanted and taken into custody. Following her detention, she was transferred to the Regional Neurologic Dispensary No. 1, where, according to her lawyer, a court order mandated her involuntary hospitalization for 30 days, and it didn't provide follow-up on whatever happened to this individual. In the United States, during the 1960s and 1970s, schizophrenia diagnoses increasingly attached to black men described as angry, suspicious, and politically militant. The cases described in the original paper entitled "This Protest Psychosis" by Bromberg and Simon overwhelmingly involved black men. Expressions about civil rights, distrust of police, or political anger were interpreted as symptoms. Jonathan Metzl, in his well-known book, The Protest Psychosis, named after this paper, argues that schizophrenia became a racialized diagnosis in the 1960s through ostensibly neutral reforms meant to reduce diagnostic bias. As American psychiatry revised the DSM to standardize and modernize diagnostic criteria, schizophrenia was reconceptualized from a, quote, reaction rooted in personality and life history, that was in DSM-1, into a discrete disease entity defined by disturbances in thought and behavior in DSM-2. Although intended to be more universal and culturally neutral, the DSM-2 definition, especially of paranoid schizophrenia, foregrounded hostility, aggression, projection, and violence, using explicitly masculinized language. These diagnostic shifts coincided with civil rights era anxieties and disproportionately captured African American men, particularly those expressing anger or resistance, recasting schizophrenia as both violent and black. I should note that in 2021, the American Psychiatric Association acknowledged and issued an apology for racist diagnosing of schizophrenia, among other failures, including the association's lack of support for civil rights and desegregation in the 1950s, 60s, and 70s. In a similar way, we see another diagnostic fabrication in the service of psychiatric abuse, excited delirium. This is a label used by law enforcement and medical examiners to justify aggressive restraint and chemical sedation, often using ketamine in police encounters. As Paul Applebaum has argued, excited delirium is not a recognized psychiatric diagnosis and lacks clear criteria, yet it has been repeatedly invoked in court to explain deaths in police custody and to absolve law enforcement of responsibility. He shows how this faux psychiatric label is used to justify forceful restraint and the administration of ketamine, a drug with significant respiratory risks, particularly against young black men. The term functions as an excuse for racist and violent policing. All of these cases differ in context and scale, but they share a common pattern. Psychiatric authority becomes ethically dangerous when it is detached from therapeutic purpose and aligned with state goals of control, eugenics, or social order. In each instance, abuse emerged not through sudden brutality, but instead through gradual diagnostic expansion, loosening confinement standards, and professional complicity. So let's talk now about the Trump executive order on homelessness. Let me just begin by acknowledging that the Trump administration's executive order identifies a real and urgent crisis. Homelessness, addiction, and serious mental illness deserve serious public investment and care, and the order presents itself as responding to that need. The ethical problem is its core approach mirrors the logic of punitive homelessness policies that criminalize visible poverty rather than address its actual causes. As Ben Barsky, Arthur Kaplan, and I argue in a forthcoming paper in Psychiatric Services, the executive order violates scientific evidence, legal precedent, and foundational ethical principles. It places involuntary confinement and treatment at the center of homelessness policy, rather than reserving them as last resort clinical interventions. The order explicitly rejects evidence-based interventions such as housing first and harm reduction programs, despite strong evidence showing that these strategies improve housing stability, health outcomes, and engagement in care, while also criminalization worsening morbidity and mortality. Legally, the order pushes an aggressive expansion of civil commitment. It threatens due process protections and seeks to unravel judicial precedents and consent decrees that limit involuntary confinement. In so doing, it destabilizes the federal-state relationship and authority and weakens disability rights protections. Ethically, it risks conscripting clinicians into operationalizing detention schemes that conflict with their professional and ethical duties. The order did not emerge out of isolation. Over the past decade or more, deinstitutionalization has increasingly been blamed for a wide variety of social failures, creating the political space for renewed enthusiasm for coercive institutional psychiatry. I myself argued in a 2015 paper with Ezekiel Emanuel and Andrea Siegel for the need to rebuild long-term psychiatric hospitals, but these were envisioned as safe sanctuaries for ethically administered high-quality psychiatric care for seriously ill and vulnerable individuals. The executive order represents a very different mission for institutional psychiatry. Abolitionist scholars Leah Harris and Liat Ben Moshe situate the executive order within a broader carceral turn, warning that psychiatric institutions, courts, and data systems are increasingly mobilized to disappear socially unwanted populations under the guise of care. They also note the risk of privatization with venture capital and for-profit prison companies, such as the GEO Group and its psychiatric hospital subsidiaries, poised to expand their quote-unquote cradle-to-grave psychiatric services. This logic has already been operationalized. Utah's planned homelessness and treatment camp pairs camping bans with forced relocation and expanded involuntary treatment, effectively making compliance with psychiatric and addiction services the only alternative to jail. It's also near Salt Lake City, but very sort of far out in in more rural Utah, so it's not connected to the city. It's very much disconnected. It's a large encampment. That's a view of it, and it has a lot of trappings of a concentration camp, in my opinion. In a recent letter, the Utah Homeless Services Board stated it would coordinate with the White House to explore becoming a national pilot for an exhaustive treatment-focused intervention for the nation. I should also mention that the planning for this predates the Trump administration, but the enthusiasm to become a national pilot is new. The executive order itself frames homelessness immediately as a threat. Its opening paragraph describes, quote, endemic vagrancy, disorderly behavior, sudden confrontations, and violent attacks, warning that failure to act leaves other citizens vulnerable to public safety threats. From the outset, unhoused individuals are portrayed as sources of danger from whom the public must be protected. Homelessness is then medicalized in sweeping terms, with the order asserting that, quote unquote, the overwhelming majority of unhoused individuals are addicted to drugs, have a mental health condition, or both. Living on the street itself is evidence of pathology. Throughout the order, danger, incapacity, and homelessness are repeatedly collapsed into a single justification for confinement. States are encouraged to adopt maximally flexible civil commitment standards, whatever that means. I guess it would be up to the individual state or municipality, for individuals deemed dangerous or unable to care for themselves, effectively treating homelessness as evidence of incompetence. The order further ties homelessness to criminality and sexual dangerousness, directing that unhoused individuals arrested for federal crimes be evaluated for civil commitment as sexually dangerous persons. Clinical care is also reconfigured into a form of surveillance. Federally funded homelessness programs are now authorized to collect health data and share it with law enforcement. Finally, the order explicitly rejects, as I mentioned, evidence-based approaches by calling for an end to housing first policies, redefining accountability as compliance rather than an aspect of individual recovery, right? Taken together, these provisions recast vulnerable human beings as administrative problems to be managed, relocated, and confined. Psychiatry is positioned not as a healing profession, but as an operation in maintaining public order. A useful point of comparison here might be, we can talk about this, Ontario's Safe Street Act of 1999, which similarly emerged in response to public anxiety about visible poverty and disorder, particularly aggressive panhandling. Like the executive order, the act framed street-level poverty as a problem of public safety and authorized coercive responses, including fines and policing, rather than addressing underlying causes, such as housing instability or income inequality. Critics rightly noted that the Act's vague standard, conduct that's, quote, likely to cause a reasonable person to be concerned for their safety, unquote, invited arbitrary enforcement. There are, however, important limits to the analogy. The Safe Streets Act operates within a stable constitutional order, was subject to judicial review, and was not just an order issued by fiat. It also does not seem to conscript psychiatry into preventative detention or medicalize homelessness itself. But let's discuss this perhaps further in discussion, as you all probably know more about the Act than I do. Some have also pointed to similarities with this executive order in recent mental health reforms in California under Governor Gavin Newsom, particularly the expansion of involuntary treatment through the Care Court Act and revisions to civil commitment standards. On the surface, both again respond to visible crises of homelessness and serious mental illness by widening the scope of coercive intervention. But again, the background conditions are very different, meaningfully different. California's reforms emerge through ordinary legislative processes. They retain judicial oversight and are framed, however controversially, as efforts to extend care within a system that continues to affirm the rule of law and the moral standing of those subject to intervention. By the way, I've just looked at some updates on the Care Court numbers, and it's hardly being used. So in terms of scale, it's not been super concerning. It's like a couple hundred people have gone through Care Court. That's both good and bad, I guess, depending on how you look at the law. The Trump executive order operates within a totally different political logic, one that weakens legal constraints, prioritizes public order over institutionalized care, and treats involuntary treatment as a means of disposal rather than care, and as a first resort, not as a last resort. So let's turn now to respect for persons and bearing witness. Psychiatric ethics cannot depend on stable institutions, procedural safeguards, and professional regulation when authoritarian conditions take hold. Those things assume shared commitments to truth, limits on coercive power, and respect for clinical judgment. One ethical anchor to psychiatry in these conditions is to very publicly return to first principles, with a particular emphasis on the principle of respect for persons in education programs, professional statements, and oversight. Just some background on respect for persons. The most influential account of respect for persons derives from Immanuel Kant. Kant holds that all persons possess a distinctive moral status simply by being persons. To be a person is to be an end in oneself, a bearer of dignity rather than mere value. Respect is therefore unconditionally required and does not depend on autonomy, rational performance, social standing, or moral achievement. It functions as a standing moral constraint on how human beings may be treated, especially in contexts involving vulnerability and coercion. There have been many, many subsequent philosophical accounts of this kind of respect. which tend to converge on a shared core idea. As philosopher Stephen Darwall has argued, respect for persons is fundamentally a matter of recognition. To respect someone is to acknowledge their moral standing when deliberating about what may permissibly be done to them. Recognition respect does not depend on admiration, esteem, or agreement. It requires simply taking seriously the fact that the person before you has a status that places limits on your actions. In this sense, respect for persons sets constraints about what must be ruled out simply because one is dealing with a person. Leon Kass links respect for persons to human dignity. In the 2008 President's Council on Bioethics report, Human Dignity and Bioethics, Kass argues that dignity does not rest on autonomy, rational capacity, social usefulness, or moral achievement, but on the sheer fact of being human. Every person is therefore owed equal respect in speech, action, and clinical judgment, regardless of mental condition, prognosis, or social worth. No life is to be deemed unworthy, and no person treated as disposable. In medicine, appeals to dignity function as safeguards against abuse, restraining power, and preventing the reduction of persons to bodies or problems. Kass traces this emphasis to the horrors of Nazi medicine and post-war commitments, embedded again in human rights laws, to ensure that no one is ever again used merely as a means to collective ends. Respect for persons understood through the lens of dignity and recognition place substantive limits on psychiatric authority. As a negative constraint, it forbids treating persons as mere ends, as worthless, or as instruments of institutional convenience. In psychiatric contexts, this prohibits the use of diagnosis, confinement, or sedation to serve non-therapeutic goals, such as social control, public reassurance, or administrative efficiency. Respect for persons also carries positive ethical demands. It requires attentiveness to individuals as persons with perspectives, histories, and lived experience on their own. In psychiatry, this includes taking seriously how coercive interventions are experienced from the patient's point of view and orienting care towards the patient's good rather than the priorities of the institution or the state. While dignity is equal, respectful treatment may differ based on needs, capacities, and circumstances. This dignity-based framework helps us to see what is ethically at stake in the Trump administration's executive order on homelessness and crime. The order recasts vulnerable human beings as administrative problems to be removed from public view. In Kass's terms, it abandons the foundational commitment to equal dignity of every human being, substituting a logic of management for the practice of respect. This is precisely the kind of moral degradation that the post-war emphasis on respect for persons and human dignity was meant to prevent. When democratic institutional safeguards erode, respect for persons and human dignity must be carried by individuals who bear witness. Bearing witness requires vigilance about how ordinary clinical acts, diagnosis, documentation, certification, these all can be repurposed to serve coercive ends. It may involve documenting the absence of clinical necessity by a clinician. It may involve refusing diagnostic cover for punitive policies. It may involve preserving accurate records or declining to participate in practices that violate core ethical commitments. As psychiatrist Bandy Lee has argued since 2016, professional silence in the face of clear danger, in the case she was describing, she was referring directly to Donald Trump himself, this silence can conflict with clinicians' obligations to public safety, especially when professional norms prioritize restraint over public engagement, which the APA has this thing called the Goldwater Rule, which prohibits psychiatrists from speaking publicly about public figures and their mental health status. Bearing witness and respect for persons may not halt authoritarian misuse of psychiatry, but they preserve moral clarity, and they clarify the limits of professional authority, and they prevent ethical collapse from becoming invisible or normalized. There are examples of resistance from within psychiatry. One of the clearest is Franco Basaglia, the Italian psychiatrist. Basaglia's resistance was shaped early in his life. As a young man in fascist Italy, he participated in anti-fascist activities and was arrested in 1944 and imprisoned. That experience sensitized him to institutions that dehumanize people. When Basaglia became director of the asylum at Gorizia in 1961, he encountered the routine use of restraints, patient humiliation, and coercion. His response began with small refusals. On his first day, he declined to sign orders authorizing restraints. The author of his biography, The Man Who Closed the Asylums, John Foote, relays comments by one of Basaglia's colleagues. Quote, on his first day as director at Gorizia, the head nurse passed him the list of people who had been tied up that night. He said, who had to be tied up that night. He said, I'm not signing. He expanded patient assemblies. Basaglia reduced coercive practices, returned personal belongings to patients, and challenged the idea that diagnosis alone should justify confinement. Basaglia's example shows that what bearing witness can look like. It involves attention to how routine clinical acts can sustain or inhibit authoritarian advances, and a willingness to accept professional risk rather than normalize acts done in the service of a strongman's ideology. So to wrap up, in this talk, I've tried to show how psychiatry is often vulnerable to and at times complicit with authoritarian regimes. The Trump executive order on homelessness and crime is an example of a drift in this direction, and it strips vulnerable individuals of their humanity, both in its rhetoric and its directives, which are unscientific, legally dubious, and unethical. Respect for persons and the practice of bearing witness preserve moral judgment when institutional protections fail. By attending to persons as persons and refusing to let harm go unacknowledged, psychiatrists and all clinicians can resist ethical erosion from becoming routine and invisible. Thank you.